pessoas que vão nos ajudar e muito a entender essa discussão, né, que é a discussão exatamente da alta complexidade, o financiamento da alta complexidade no nosso país. Então, vocês já viram, nós estamos aqui com o nosso ex-ministro da Saúde, o Nelson Teich, pessoa que a gente já conhece há muitos anos, e que penso que todos nós brasileiros devemos, assim, saudá-lo pelas ações e pelas atitudes que ele tomou enquanto ministro da Saúde. Prazer em recebê-lo aqui, Nelson. Tenho certeza que a gente vai ter um bom momento aqui. Queria também apresentar, claro, sei que já foi apresentado, o nosso colega, né, José Cechin, que também já foi nosso ministro da Previdência, ou seja, também tem uma experiência alta e grande, do ponto de vista de financiamento de uma sociedade como um todo, de benefícios sociais como um todo, e hoje desempenha um papel muito interessante enquanto estudioso à frente do IESS, que é o Instituto que estuda exatamente tudo aquilo que a gente tem sobre medicina suplementar no nosso país. E o nosso amigo de todos nós, o doutor Alexandre Ruschi. Né? O doutor Alexandre Ruschi, uma personalidade importante do setor de saúde, foi durante muitos anos presidente da Unimeds, como é que se chama? Central Unimed? Da Central Nacional Unimed, e desempenhou... CNU, pronto, isso aí. Esqueci que todo Francisco chama Chico. Esqueci o apelido, CNU. Então, dentro da CNU, desempenhou um papel importantíssimo na análise, divisão e desenvolvimento do setor, e hoje está concentrado bastante no seu estado, que é o Espírito Santo, que é um estado que tem bastante beija-flor, né? Já que o nome do nosso curso que lembra exatamente um dos maiores, se não o maior, né, dos especialistas em beija-flor do mundo, né? O Dr. Ruschi foi exatamente aquele que todos nós brasileiros temos também que saudar. Então, amigos, nós vamos iniciar esta conversa. Cada um de vocês tem 10, 15 minutos para fazer as suas considerações iniciais, depois a gente volta para um papo. Né? Se vocês me permitirem, então eu vou começar pela visão do Nelson, para que ele possa dar para nós a visão enquanto setor público de saúde, setor geral. Depois, o José Cechin, para que coloque para nós a visão exatamente da medicina suplementar. E depois o Alexandre Ruschi, que vai dar para nós a visão do operador, né? Daquele que está lá no dia a dia, frente a frente a essa necessidade de financiar e beneficiar essas complexidades. Então, obrigado, gente. Vamos, tenho certeza absoluta que vamos, ao final disso, ter um bom período. Nelson, por favor, muito obrigado. O palco é seu. Bom dia.
Bom, primeiro quero agradecer a oportunidade de estar aqui, estar com vocês. É sempre um prazer estar junto em algum momento, né? Já está aí há um bom tempo. Essa parte do financiamento é uma discussão bem difícil e delicada, e o que é mais importante para mim hoje é que a gente consiga entender realmente qual é o nosso recurso financeiro. Porque eu vejo discussões de avaliação de tecnologia, de incorporação tecnológica, discutindo uma metodologia que é usada há 45, 50 anos atrás, que é a método de avaliação econômica, que é baseado na disposição para pagar. Ele tem alguns conceitos que são, não vou entrar em detalhes nisso agora, mas os conceitos que são pouco abstratos, pouco fundamentados, mas o problema todo é o seguinte: com a evolução que a gente teve, com a complexidade da saúde, com tudo que aconteceu, você ter uma discussão de financiamento com base na tua disposição para pagar é totalmente sem sentido. Ela tem que começar sempre na tua capacidade para pagar. Porque senão você começa a trabalhar como se a vida fosse como se você gostaria que ela fosse, não como ela realmente é. E a tua única chance de enfrentar um problema é trazer ele para a realidade. Então, eu vou te dar uns números só para a gente entender o que acontece. Quando a gente fala em alta complexidade, a gente fala em inovação, a gente fala em coisas de padrão mundial. Né? As inovações são um padrão mundial, elas não são como, por exemplo, uma droga que já perdeu a patente, é genérica e você tem aquilo que você pode usar de uma forma mais barata. Mas a inovação ela é sempre carregada num padrão mundial e ela sempre é cara. Só você vê a discussão de vacina, você vê a discussão dessas drogas novas que estão saindo para a Covid, você vê a discussão das drogas oncológicas. Então, essa parte do financiamento, então, só para a gente, eu sempre tento contextualizar na hora que eu vou falar sobre isso. Eu vou pegar dados de 2018 upper e lower, né? O gasto médio por pessoa por ano em 2018 pelo Banco Mundial dos países de alta renda foi mais ou menos $5.560. Quando você vai para os países que eles chamam de upper middle, que é a segunda grupo, que é onde o Brasil se encaixa, isso cai de 5.500 para 486. É um abismo. Quando você sai para o lower middle, isso vai para 86. Quando você vai para o país de baixa renda, cai para 32. Então existe um abismo financeiro no mundo entre os países ricos e os países não ricos. Tá? Então, trazendo um pouco para os números do Brasil, quando você vai para 2020, o número que eu tenho é baseado no estudo da FIS, que é um estudo. Normalmente, o financiamento da saúde no Brasil você tem mais ou menos 41,5% que é público, e o restante, né, os outros 58,5% mais ou menos, um pouquinho mais da metade é gasto do bolso, é alta forma, não é saúde suplementar. Todo mundo acha que não é público e é saúde suplementar, não é isso. E, geralmente, quanto mais pobre é um país, mais você tem gasto do bolso, mais as pessoas têm que financiar a sua própria saúde. Então, aí quando você vai trabalhar o sistema público, a gente tem mais ou menos 365 milhões de pessoas, 52 milhões no sistema público, no sistema privado está com 48,5, mais ou menos, 48,700. Fora o grupo militar, que deve dar mais ou menos 1.300.000.
Que son aproximadamente 1.300.000 personas, en el sistema público tenemos un gasto per cápita
Que é na faixa que dá menos de R$2.000 por pessoa por ano. Isso é dividido em federal, estadual e municipal. Verba parlamentar agora está por discussão aí, mas já começa a ter um pacote de legislação importante. Quando você vai para o país da incorporação que são os Estados Unidos, são R$67.000 por pessoa por ano para gastar contra R$2.000. Brasil, para o Reino Unido, que é um país que é a referência do nosso SUS, está R$30.000 por pessoa por ano. Quando você vai para a saúde suplementar, não sei se o número que você aqui tem é esse, mas o número que eu tenho da FIS, você tem mais ou menos uns R$4.700, R$4.800 por pessoa por ano para gastar. Então está muito mais perto do SUS do que do país rico. Então, a gente tem que entender qual é a realidade brasileira. Isso é o que a gente tem para funcionar. Então, qual a importância prática disso? Mesmo que você aumente significativamente um percentual do que você gasta em saúde, ainda vai estar muito longe dos países que incorporam muito. E a gente viu isso na época da vacina. Levam vantagem quando eles têm que competir na busca de coisas que estão chegando de... Né? A Covid trouxe uma coisa muito interessante, que foi realmente a competição. Então, a gente viu o que é uma competição mundial, como o dinheiro, como o poder financeiro faz diferença. Então, essa é a realidade que a gente viu. Por que eu estou falando isso? Às vezes eu vejo as pessoas falando, não, porque o Brasil gasta 11% do PIB igual a um país rico europeu que gasta 11%. O percentual do PIB gasto em saúde só significa qual a importância que um país dá para aquilo. Não quer dizer o recurso financeiro que ele tem. Porque o percentual de pouco é pouco, o percentual de muito é muito. Então, isso aí nunca vai ser... Isso é muito mais uma decisão de como um país define as suas prioridades do que realmente uma fonte de recursos. Por que eu estou falando isso? Tá? Quando você vai trazer a incorporação, outra coisa que eu até estou tentando entender, mas eu vejo as pessoas falando, você tem atenção primária no SUS, né? Atenção primária, alta e média complexidade. A alta complexidade está mais ligada ao governo federal, né? Você tem atenção primária mais no município. Então, eu vejo isso, quer dizer, a saúde ela é um contínuo. Então, embora a gente discuta alta complexidade, e quando você compara o SUS e saúde suplementar, tem mais alta complexidade no SUS do que na saúde suplementar. O percentual gasto do dinheiro no SUS tem mais dinheiro alocado em alta complexidade do que no suplementar. E você vê qual o problema que eu vejo hoje na alocação de recursos. A alocação de recursos hoje ela não é baseada numa estratégia, num planejamento. Ela é muito mais uma ação e reação. E qual é o problema prático que você tem nisso? Por exemplo, está a oncologia. Na oncologia, o percentual de gasto na oncologia é de mais ou menos 5, 6%. Oncologia é alta complexidade. Então, você está falando em diagnóstico, rádios, quimioterapia, cirurgia, tudo isso é alta complexidade. Então, o que acontece na prática? Que seria o ideal no meu financiamento da alta complexidade, vou citar a oncologia como exemplo, só para a gente ter um exemplo real. O que seria o ideal? Que eu pegasse, sei lá, 6%, não depende de onde ele vem, quanto vem do Estado, município, federal. A alta complexidade é assim, olha, eu tenho tanto para gastar, eu vou gastar tanto em diagnóstico, tanto em terapia, tanto em radioterapia, tanto em cirurgia, tanto em cuidado paliativo. Treinamento é fundamental, porque as novas tecnologias, em geral, infelizmente, elas não são tecnologias que elas elevam o padrão médio da pessoa, do profissional. São cirurgias que dependem de profissionais cada vez mais qualificados. Estou dando um exemplo bobo. O que seria o ideal? Que numa cirurgia robótica, que o robô ajudasse o médico a ser melhor. Mas, na verdade, você precisa de um médico cada vez mais competente em cirurgia robótica para poder usar o recurso que tem da máquina. Então, a mão que faz é o seguinte, você precisa de profissionais cada vez mais competentes. O que faz com que seja cada vez mais difícil você ter profissionais em grande quantidade e ter uma distribuição com equidade pelo país. Que é um país muito heterogêneo. Na verdade, para o Brasil, nada você pode fazer na média. É tanta heterogeneidade que não existe média no Brasil. Então, você tem que definir cada segmento. Então, o que acontece hoje? Você precisa ter... O que seria o ideal? Por exemplo, olha, eu vou gastar tanto nessa alta complexidade, assim que eu vou alocar. Quando você não faz isso, quando não é você que, por estratégia e planejamento do FIT, como você vai alocar o seu recurso financeiro, o que acaba acontecendo é que esse valor que é alocado à alta complexidade acaba sendo muito mais resultado de uma pressão de quem faz do que realmente por uma estratégia. Por que eu te digo isso? Quando você olha, por exemplo, dentro do gasto em oncologia, isso é um dado que eu tenho da Europa, você tem um gasto em oncologia na Europa, é muito heterogêneo, mas aí eu vou usar a média, está mais ou menos 5,9%, de 1995 a 2018, saiu de 5,9% para 6,1%, 6,2% do gasto em saúde. Só que o gasto com quimioterapia saiu de mais ou menos 10% para 30%. Então você começa a ter um deslocamento da forma como você gasta o dinheiro, quando na verdade é baseado muito mais na força, na pressão de incorporação, do que uma decisão estratégica de qual é a melhor forma de alocar o seu dinheiro. Então, eu acho que a gente pode seguir depois nas perguntas, mas eu só quero deixar claro que a gente hoje precisa, primeiro, de muita informação. Eu preciso saber qual é a necessidade da sociedade, qual o recurso financeiro que eu tenho, como é que eu vou alocar. E o que eu digo sempre para o gestor é o seguinte, né? Quer dizer, eu sempre, hoje em dia, às vezes as pessoas me perguntavam qual é o melhor ministro, né? Se é o político ou é o médico. Eu digo dos dois, você é um gestor. Os dois são ruins, tanto o político. Se você é político ou é médico, você não quer dizer que você tenha competência como gestão. Então, a decisão de quem vai estar lá tem que ser uma decisão de gestor. E como gestor, você tem que ter informação de três coisas: financiamento, operação e entrega. Porque você tem o dinheiro, com o que você entrega, o que você opera, porque a gente fala muito em acesso. Você tem que lembrar que acesso é só o processo, o que vale é o que entrega. Se você tiver acesso, a qualidade do atendimento é ruim, a entrega vai ser ruim. Então, a gente trabalhar acesso como se fosse entrega é um outro erro.
And delivery is another mistake we should stop making, and we should start measuring that in detail. And from then on, you have a structural manager that you're going to work on, and your resource allocation has to be based on what you have and what you see as your ability to improve what you're going to do. So how much you allocate to primary care, middle complexity, high complexity. Just to give you an idea, at SUS, when you talk about primary care, middle and high complexity, it's about 4,000 procedures in terms of complexity. When you see primary care, only 744. So high complexity. So the bulk is in middle complexity. How are you going to behave? So how you need the information, how are you going to define the need of society, the ability you have, the financial resources, so you can get through them, what you're going to define, and of creating a more efficient system. So I think I'm going to leave the comments here so we can work a bit more on questions. Thank you very much. Up to you. Thank you very much, Nelson. So your kickoff has been very interesting.
Your kickoff was very interesting.
You,
your kickoff was very interesting. Good afternoon. Just a little bit, I'm a little bit different from the other panelists. I am an engineer and all my colleagues are physicians. So you expect more numbers from me than Nelson just gave. Well, by the way, very interesting. About your numbers, Nelson, I would just make a very brief comment, the following. we have a level of absolute expenditure similar to advanced country. You would need to spend such a high share of our income that would be so high that we wouldn't be left with anything else. If we spend all our income with health, we would be close to what they spend. Well, that's impossible. So we always need to look at percentage of the GDP because this shows the effort society makes for health, as you reminded us very well. So we start our life consuming well before then we start producing. So we consume milk, bottles, baby food, diapers, and we also end our lives consuming without producing. So these two extremes of the populational pyramid, the children and elderly, people consume without producing. And who supports them then? Of course, those in active work, parents looking after their children. And now parents that look after their own parents, the grandparents of their children. And voluntary from children to parent, and also voluntary in terms of children with their parents, the grandparents, and sometimes the state forces young people to look after their elderly. In the case of the elderly, I think that more than 99% of them were not able to accumulate property to live without depending either from the state or from their own children. Of course, in this consumption includes health services that are complex and all attention levels, secondary, high complexity, and etc. The solution for advanced ages that do not depend only on what children want came from pension funds from Bismarck 180 years ago. The solution he proposes was based on contributions that will build a fund where the income for retirement would come from that would serve to cost healthcare too. So it can be organized in different financial systems. So it can be mutual, simple partition, mutual with solidarity sharing, and then or with strictly individual funds. Each one has its advantages and disadvantages. I'm not going to go into that. In the case of health, Bismarck followed the principles of insurance. Only those who contribute are entitled. In England, the system was slightly different already during World War II. Everyone is entitled because funding comes from tax. That's why they have the NHS and our SUS partly copies our SUS copies the NHS, which is partly adopted in other countries. Now in Brazil, the health plans follows Bismarck, and the public follows another theoretical concept. So SUS was always part of the Bismarckian pension ever since we started having it here in Brazil with the law that was enacted in 1923. It will be 100 years old in 2 years. And SUS then adopted the system funded by taxes, in the Brazilian case by contributions that are specifically allocated and dedicated to social security. SUS, for example, is for everyone, but some people, in addition to having the SUS and keeping that right, also have health plans according to the Bismarckian concept of insurance. What is the problem of the funding and what I'm saying here? The problem is that people usually have an income during their active years while they're working. It's a period when health expenditures are not high and risk is not high. And these people usually can have a corporate health plan. Now, when the person leaves the job market because of age, those who had a corporate plan lose, and the income goes down, and expenses with health go up. And there are more chronic diseases and expenditures with health go up with age. It's very difficult for the elderly to pay their health plan during retirement because it's very expensive and also because the income is very low. It's impossible to imagine that Brazilians will take a little bit more than 1,000 BRL to pay a health plan from an income that is about 1,400 BRL. It's financially impossible. What's the option then? What option do those people who leave the job market have? Well, the very, very few that have accumulated properties or a state that will live off that or count on their children, or they will count on the public system, SUS. But can we think of alternatives? Yes, I think so. Yes, of course we may. And the idea is to combine pension and health, as Brazil has historically done. Why wouldn't we use this phase of life called active life, when people work, have income, have a corporate plan, to build savings, whatever name of savings, pension, an individual fund, from where they may withdraw once they leave the health market because they have retired, to bear the costs of healthcare. So to bear the costs of healthcare, to pay directly for healthcare costs that they may need, would require a very, very large fund. Today, a treatment, a cancer treatment, and Dr. Teich may tell me, it costs as much as 1 million BRL. So very few people have that capacity. So this fund would not be formed to pay for healthcare out of pocket because it's way too expensive, but it would be feasible to build a fund from where you could take out a share to pay part of your health plan, which is expensive when you are older. I think that this system is perfectly feasible. So the instruments necessary to do that exist. Well, we have more than 50 or 60 years, about 6 decades of health plans. When we have more than 5 decades of closed pension plans, several decades of open pension funds that have been working without any major legal issues. And they have been working appropriately. Today, these systems already accumulate an amount, and I don't have up-to-date figures, but certainly it's much more than 20% of the GDP in terms of accumulated funds for these pension funds. And then question is, why shouldn't we use these institutional apparatus that are already operational to solve the temporal issue of the discrepancy between high expenditures when the person doesn't have income with lower health incomes when the person has income? Why not have a plan or a system that we call pension, health, pension, health, savings, bonds, whatever you may call it, but it would be a health plan during their active working life to meet the needs of the current risks, and combined to it an accumulation plan. And they would contribute every month so that they could start taking out from it when they get to, say, to 65 or even later, once they leave the job market. This is a solution between pension and health. It's a combination. So we could call it capitalized health. You can call it whatever, but it would be good. So soon as the person joins the job market, so the younger the better, and then the less the monthly amount that they would have to pay, so they would choose a good health plan once they leave the job market. Meaning, yes, we have everything necessary to do that. Now we would need to have some incentive to encourage people to save a little bit more during their working life to build this fund that will help them once they are retired. When health expenses are high and plans are very expensive. However, people are very short-sighted. People favor the present and only think on the short term and forget about the future. So one day we are going to be old and we'll need lots of healthcare services. So people will need this encouragement. However, the current situation of the country, and I am afraid it will still last for some other time, prevents us from discussing incentives like these, much to the opposite, what we hear from everywhere. We need to end or at least reduce considerably the incentives that we have. I am optimistic. We are going to leave the bad situation we are in now. We just need to have political leaders with the correct visions. I am well aware that optimistic is not really very helpful, as John Galbraith would say, but pessimism is a big problem. So Balestrin and my fellow panelists, Teich and Alexander, I am an optimistic. Thank you very much. Thank you for your very good presentation. And more than that, thank you for this drop of optimism that you have left us with. Thank you. Alexandre, please now, the floor is yours. Let's see how we are going to solve this. Good morning, everyone. My special greetings to José Villar. And when I meet him in person, I will need to tell him off because, well, this is a very difficult theme to put friends to debate. That's difficult. So good morning, Balestrin, Nelson, and Cechin. I'm very happy to be here with you. Well, Nelson and Zé have greatly facilitated my task because they have expressed two very important visions in a scenario that we set ourselves to talk about today. Cechin, we have more than 1 trillion BRL of reserves in open pension plans, more than 1 trillion. This is information from 2019. So there's a lot of money. So what Zé said, this discussion exists, but it's kind of on a standstill. The forces that we know very well in this country, this discussion is not evolving. It's in a dispute that doesn't make any sense between SUSEP and ENTREPRENEURSHIP fighting. Who was going to rule or to look after this issue? You know what I'm talking about. This is an alternative that has become very relevant in many other countries, and it's very interesting for us. The only thing is we can't have a fight or a competition for who's going to coordinate. This discussion exists, and for 8 years, I worked in insurance with a technical director of Unimeds, right when we had the hope that this would evolve very fast, and it didn't, which is very bad for us to run that risk. Well, first of all, I would like to go against the myth that supplemental health does not fund high complexity in the country. There's almost a dogma in society that everything that is high complexity supplemental health pushes to SUS. It's not true. Supplemental health is an important funder of high complexity as set forth in the contracts, and we have a list of coverage that is very extensive, encompassing almost the entire international classification of diseases, almost 100% of it, with very few exceptions. So yeah, society has an important contribution by supplemental health in costing high complexity in the many opportunities when they need to have access to that. Another thing that maybe I could mention, it's very a big problem for us here in the country, is that we have supplemental and public health working very different. Where in the public health we have Conitec assessing the incorporation of technologies, it does not apply to supplemental health. And then we are limited to listing updates that are addressed at the National Health Agency. It's as if we had two healths. We just don't have two. We have just one health, just one. One is public, the other one is private. So we could have just one approach when we think of incorporations and everything. So we spend energy and we also miss the opportunity when we are in incorporations that are meant for the public healthcare system and those meant for the supplemental health system. Another very important theme for us, and we cannot escape this discussion, is that we have copied a healthcare model that is not well adapted to a country as poor as ours. It's impossible to have the healthcare model that the country offers to society without us rethinking which is this model, how can we coordinate and integrate it better, how can we somehow provide us all a much better delivery, looking at quality, not just how much we are going to spend. It doesn't make any more sense, and it's impossible now for us to evolve on that issue in the country unless we discuss access to healthcare and not discussing the healthcare model. And of course, we need to think of compensation models, not looking retrospectively, but that will look especially prospectively to the costs involved. And we are very, very late with that regard in the country. So many of our providers refuse to debate this question. And this is also the result of our very bad evolution in terms of our evolution in health. We really lack information with that regard when we want to design a new model, especially when we want to design a new compensation model. If we take countries that are very close to us, like Portugal since the 80s or 90s, and once we use the model that was developed in Yale, so we use DRG as the hospital compensation model, and they work very well with DRG across the hospital structure, lending a little bit more rationality to it and delivery with higher quality. In Brazil, we are getting away from these discussions. We don't have any structure in supplemental health that is definitely compensating prospectively. There are a few trials that are quite a few trials that are relevant in terms of reconfiguring the funding structure, but we're losing very precious time for us not to go into a spiral that may be from where there's no return. My concern is that this trajectory we are going towards, we might not find a solution to this issue, and definitely we should discuss the quality of the deliveries than just funding forms and where we are going to get money from here or there. So even in the public healthcare system that built a model that really makes sense, we cannot make the system be perceived by society. Brazilian society is still very much charmed by a disorganized health access model, free access to health, and the public healthcare system cannot show to society which is the best way, and the best way is a way that coordinates care and provides access through collective health programs. And in this manner, we may go to second and third levels of reference in an orderly way, and then referencing it back so that we may have an efficient monitoring of our health.
We commented a bit earlier when we were talking before we started our panel that it is surreal to see the behavior of Brazilian society regarding access to health. People, regardless whether it's public or private health, they have this sort of immediate attitude. So we gave them that. So the free access to healthcare structure did not require any kind of structuring of care, any kind of guidance. And this is very bad because now this turns us into having the need to re-guide the behavior of society, a topic that is very delicate, which is access to health. Of course, everyone, when they wake up in the morning with a headache, they think about the worst of evils, despite the fact that worst of evils that statistically has little relevance when we think about just a mere headache. So in my view, the vision of complementary health, we have a strategy that is not well guided in terms of reorganizing the power and all of this with little initiative so that we have a model that really delivers more coordinated healthcare with more quality that can actually preserve healthcare, promote health, and not only treating diseases in a episodic fashion as we have today. And the second step would be a debate that has been delayed greatly. How can we resolve the issue of compensation in service provision, not only looking retrospectively, but also making the whole chain of health to be compromised or committed actually to the results. Commitment to results actually is not in charge of anyone. The individual is not even concerned about the results or the outcome. They do not actually become part of the care. The individual is perhaps the most important part in coordinating care, which is something that we haven't been seeing. These would be some brief remarks. Thank you, Balestrin. So I'm available for us to talk a bit more about it. Thank you very much, Alexandre. You have closed greatly the initial considerations. I'm going to go back briefly. So we have 15 minutes to have a brief chat. So see how we have so we have a little seed sown for our conversation. I'm going to go back to Nelson's to keep the same order since we haven't heard him for a long time. I'd like to say the following. I always like to comment. So how frequently do you make it? When you made it, and I watched you making this comment, I was very impacted by it. So much so that sometimes I use it and I've even copied what you said. You said the following. We in our country or in other countries, we have the habit of talking about great things in a simplistic way. So when we talk about a million seconds, we're talking about days. When we're talking about billion days, we're talking about 30 years. So it's increased a lot. When we talk about the 1 trillion seconds, we're talking about 30,000 years. Not even 30 years to resolve this question. I'm going to ask you, who had the opportunity of being our Minister of Health, and obviously had this observation regarding this, how do you see this process of organization so that we can actually have a system that is a health system that is organized, a proposal of financing that is clear, organization, and things that are well done. So what I remember when I was at 9, we made the white book. One of our proposals actually was to create an agency following the models of NICE. I know you know it quite well. I'd like you or José Cechin to briefly comment in it. And it can be sort of halfway through of what you mentioned of Polytech on one side and NS on the other side. Please, let me see. Well, what you said is quite interesting for people to understand the context of this million, billion, trillion, because we talk about these numbers and many times they are very abstract to us. I had mentioned that in the US, if you look at the spending in the US last year in 2020 was $4 trillion. They have 331 million inhabitants. Brazilian GDP in 2020 was $1.37 trillion. So what we spent in healthcare in the US is 2.5 times Brazilian GDP. And we have 230 million inhabitants. So they spent $4 trillion and we spent $137 million, public, private, and everything. So just to give you an idea, 1 million seconds ago, so 2 weeks ago, 1 billion seconds ago, it was 1989 when the first office package was launched, and 1 trillion seconds ago, 30,000 before Christ. So it's a huge difference. So what are we talking about? Financing. If you make clear how little funds you have compared to rich countries is important, because this highlights the need of efficiency of your, it's as to how you're going to spend your money. This is fundamental. So this only highlights that no matter how, even if you get some more money, what matters is the money you have. If you're efficient, you can help many more people. So this need of working system efficiency is absolutely fundamental. So what I had suggested something, because I worked as a minister, I was an assistant. I made 2 reports, one on oncology and one in the corporation and technological evaluation. And adding to what Alexandre said, my suggestion is that an agency should be created. It's an intelligence agency. So evaluation and cooperation has to be a tool for a strategy for the country. And you must have information. Again, based on what Alexandre said, payment for services, payment for funding. Actually, well, one encourages to treat more and the other one treat less, but neither of the two encourages you to treat correctly. So you only treat correctly when you measure clinical outcomes. So there's been a complexity in the system and our ability of information and management has not followed it. So the first thing we have to set up is an information system that allows us to understand the 3 branches: amendments, financing, operation, and delivery. You have to be able to measure the needs of society, well, in terms of cancer, cardiovascular, diabetes, etc. You will define the distribution. So it would be just like making a budget, and then you have to follow from the budget that you have, and then you can start measuring what is being delivered. Even the payment per service, if you a fee for service. So if you measure the outcome, you can see the institutions that deliver better. So you can take the institutions, say, okay, those are the ones that are delivering the best clinical outcome. So what am I going to negotiate with you? I'm going to actually send more people to you, and I'm going to lower the value. I'm going to give you value, and you're going to work with you because I know your clinical delivery is the best one. Well, actually, you can move towards efficiency in any compensation model. You cannot mix up tool with solution. Solution is the way you use the tool and not itself. The way of compensation may be well used or poorly used, whatever it is. But this kind of more technical reasoning, etc., to define the way you're going to use your financial resource that you have and how you're going to create incentives, how you're going to monitor them. So it's no use for me to get to a place and see how many appointments the doctor has. They may have 300 appointments, not even look at the people, and the outcome would be poor. So I cannot measure only volume. I cannot say that the doctor is good because he has a lot or they have a lot of appointments. So you have to see the outcome. So you have to consider all of that to design a system that has minimally a strategy, a planning, a follow-up that allows you to have continuous improvement. Because in health, you have that. And you have things that are transformed. I think you've mentioned that. The last drug launched in the United States was $2 million in 2018. The average price of an oncology drug was $775 and over 900,000 reais. So this is the path we're following towards. So if we don't stop to see, we're not going to evolve. How can we work on this strategy, our planning, our efficiency? So the system will be increasingly the way it moves. So it moves the way it is. You go after it, but you're not the one managing it. So the less we manage the system, more unequal it will be and more inequality we'll have in society. This is the greatest problem we have in society, inequity. This is the most difficult part. Okay? Very good, Nelson. This is it. Cechin. Every time I hear you talk, and I heard you talking many times with great pleasure, I must say, you form your arguments in a very clear way. You present them in a way leaving few questions regarding everything you say, and I admire a lot every time you talk because I think they are very rational. But sometimes I notice that we're living in a world where we lack this rationality that I so much admire in your talks. I'd like you to comment a bit. How do you think we can bring a bit of rationality to this environment of uncertainties as you put to us? How can we bring a bit of rationality so that we can actually not finance? Because actually what you're saying is the following, health plan. So I'm going to be able to pay health insurance when I'm older through savings that I can make. But how will this health insurance pay for the procedures that are considered so exorbitant, as Nelson just mentioned? Thank you for your words, Balestrin. I consider generosity a friend. So I had great training in math at the time of university. I had 8 hours a week of mathematics. We get used to this logic reasoning, and I went through difficulties on other types of topics. When questions were not so clear as they were in math, although we can argue on those lines. So I think the question that you put to us is not simple, Balestrin. It involves 2 dimensions, all of them complex. One of them is the interest, the objective interest in the result, the financial aspects, profit, if you may, that is put there and cannot be left out. Actually, investors invest always thinking about the return. Health is only one of the industries, and it cannot be systematically lower return than the rest of the economy. This is one of the aspects. And there are always questions when you propose change. Am I going to keep this return rate? Am I going to be actually chopped somehow? Am I going to actually get some cuts in this? So this requires initiatives of changes. The other is the mental aspect, the fears people have of changing, of moving on with things. Changes always cause uncertainties, and people hate uncertainties of all kinds, even speculators. They like to speculate, but they don't, in their minds, they have some certainty, and they move this way. So, Balestrin, sorry to say that it is a difficult topic, and there is no appropriate measurements for that. What is appropriate here? I think that actually what I read about health efficiency that we have in healthcare is very low. So this is a question that has to be equated. So to increase efficiency in the provision of healthcare, and this is also in the use. Sometimes the patient that uses and inadvertently produces waste or demands waste. And this has to be done efficiently or minimum resources, and it has to be effective. And we have to have appropriate delivery that people wish, and population needs to be in good health. So we can follow long paths. I like it a lot, but time is almost up. But I'm going to stop here, Balestrin. Thank you very much, Cechin. And you've addressed a point that is very important, which is waste, right? Because I had the opportunity of participating in innovations of OECD in terms of waste and how to debate them, and saying that waste in the world was estimated in healthcare of $300 billion.
You made the comment that maybe you thought that our supplemental health agency could be more operation focused. It could be more focused on the pursuit of the solution for certain problems that sometimes arise that may seem impossible to solve, but they're not. So could you focus a little bit more on this theme? Well, first of all, I need to consider that 20 years ago, when this industry had no, and then it
todo mundo.